certificates and our points after the webinar has ended. So we urge that we be very keen. And then we also urge that once you've not received your CPTs, you wait for at least 24 hours before you can check with us. Otherwise, I believe our presenter is on and we can allow him to proceed. Mr. Agri Marube, if you can hear me, please take it away.
Yes, Maria, can hear you clearly. Thank you for the introduction and really appreciate your audience and having given me this opportunity so that I can present in this CME. And I welcome on board each and everyone so that we can learn together. Today we are going to learn, as stated, we are going to learn about handling priority specimens and tests for urgent clinical decisions. This is a very crucial topic because this is a life-saving knowledge that we need to have so that at least we can play our role and God does the rest. So we're going to look at various issues on priority specimens and urgent tests, priority tests for urgent clinical decisions. So the overview of the presentation will entail defining what urgent specimens are and what urgent tests are. We're going to look at a list of priority specimens, key aspects of specimen prioritization, also prioritization of specimens and critical results reporting. We're going to look at the general rule on priority, in brackets, urgent clinical decisions. What are these urgent clinical decisions? And what's the general rule for urgent clinical decisions? And then lastly, but not least, we are going to look at public health priority specimens and the protocols that are stated, especially in public health international protocols. So we're going to define what priority specimens are. A priority specimen for analysis refers to biological sample that must be processed and analyzed by a laboratory with greater urgency than routine specimens due to the critical nature of the patient's condition or the time-sensitive diagnostic information they provide. This ensures prompt clinical decisions and initiation of treatment for serious life-threatening conditions. So basically, that's what it means by priority specimen. There are key aspects of specimen prioritization, and we are going to look at them. So we have clinical urgency. That's usually coined as stats or named as stats. Laboratories trial specimens based on established criteria to manage high volumes and ensure the most critical cases are addressed first. So there is this issue that we are going to look at on the issue concerning with triage. Triage is not only for nurses who triage patients at the front. When specimens come into the lab, we also have to triage them. Triage is looking among what you have and seeing and checking what priority process are you going to follow, if there is any. And we're going to look at that. They are typically these are typically for medical emergencies. Specimens specifically marked as stats or short form statim. Statim comes from a Latin word meaning immediately. So in science we use a lot of Latin words. There are so many, and these ones have been brought on board courtesy of scientific world. into English language. So it means immediately. These samples are given the highest priority and I would like to emphasize highest priority for immediate processing. We are going to look at some issue in consideration, and that is specimen source. Samples from normally sterile body fluids are almost always high priority because any microbial growth may indicate a severe infection. Examples are cerebrospinal fluid or CSF for suspected meningitis, blood culture from septic patients, and other sterile body fluids. All these are treated with urgency and greatest urgency. These are stat specimens always. In handling of priority specimens or priority tests, we also consider the patient's status. Patients from critically ill, specimens from critically ill patients, e.g., patients in ICU, or immunocompromised patients, e.g., transplant patients, chemotherapy patients, are often prioritized due to their vulnerability to severe infections. And these patients are in critical situations. Some of them need urgent measures to be undertaken by clinicians. So we have to handle all their samples in high priority manner. So this one tells us the urgency of handling of prioritizing depending on patient condition. We have critically ill patients also because they are exposed to severe infections like sepsis, and these are given high priority, as I've stated. Immunocompromised patients, the same, because of their weak immunity, and they're susceptible to opportunistic infection. So cases needs to be handled efficiently and fast. So these samples are usually marked as stats. And any sample that has been seen as stat is an urgent sample. It should be handled with the greatest urgency possible. In line with this, we need to have also clinical information prompting us to handle or prioritize the sample or specimen. And this can be from a physician request. Yes, this clinical information is key. That's why in requests, there is a great importance for I think it's a general rule. It should be a general rule for any request, whether it's electronic request or physical request, to have a brief clinical history or clinical information, because this one is basically a guide to know what we are handling in front of us. The information provided by the physician, such as suspected pathogen, e.g., rule out malaria, or specific clinical history, can influence the prioritization level. You see, this is one of the importance of the clinical history. The travel history is also key, which can also be indicated in the clinical picture. Patients who have traveled to areas with known outbreaks or endemic areas are often prioritized for testing. There are these high-risk diseases, especially samples from suspected cases like polio. And even a single suspected polio case is handled as an outbreak. So these are cases that are that are key, especially in prioritization of testing. We have polio, rabies, or anthrax. If these infections are confirmed, then we need to handle such suspected cases with high priority. We should note that effective prioritization helps prevent backlogs and ensure that actionable data is available to decision makers in a timely manner, directly impacting patients' care and outcome. So we see how the lab plays a very important and key role in saving lives. Yes, because we impact patient care outcomes. If we delay in some cases, we might be endangering patients' lives. Okay, continued. In continuation of this, priority can be based on specific protocols. There are protocols that that enforce prioritization, especially specimens that are scheduled for research or earmarked for research and surveillance. For surveillance, there are constant checks whether there is any trace of outbreak anywhere in any region which has been earmarked. And this is key. Research specimens, some protocols give high priority to research specimens because of certain protocols that are involved. There are some contexts such as biological specimen collections for database priority specimens. And these ones we can refer to protocols, especially the ones that have been laid down in research, in the research project. Specific research needs also are key in prioritization. For example, in the context of a particular study or public health initiative, specific specimens may be designated as priority. Now, this is where prioritization changes because of the nature of the case that we are handling. Prioritization levels. While we have specific categories that can vary from laboratory to another, there are common prioritization levels that are across the board. Now we have start/critical. Any start or critical specimen or test sample should be processed immediately. This is as a rule. Whichever lab that you are in this world, start or critical specimen or tests should be processed immediately. Typically with a goal turnaround time within 1 hour. It doesn't mean that it has to reach 1 hour. It can be less. It can be less even at 30 minutes or 20. The less time possible. High priority specimens are processed within a few hours, e.g. certain respiratory samples from ventilated patients. We also have routine specimens or routine tests. Routine tests are usually processed within the standard daily workflow. There are also batch tests or batch samples. These are collected and processed together at a specific time. These batch samples, they usually have to meet a certain number. For example, to fit a certain cartridge so that we don't miss, we don't waste resources, we don't waste extra tests. They are collected and processed together at a specific time. It's good to know that other specimens can become high priority depending on the clinical presentation and the need for rapid diagnosis. For instance, we have blood glucose, and we have also a test for malaria parasites. how can random blood glucose test become an emergency test or a start test? Why? It's because of it can be the nature of the patient. Maybe the patient collapsed and we are suspecting hypoglycemia or DKA, a diabetic ketoacidosis. So this has to be handled immediately so that we can save a person's life. We know whether it's DKA or it is hypoglycemic coma, so that it's handled immediately, so that antidotes are provided to save this patient's life. Because you give a wrong prescription in a wrong range of blood glucose, you are killing the patient. So urgent resources are needed here. Malaria parasites, malaria is a killer, as we all know. If critical cases of malaria, especially high parasitemic cases, are not handled with care, there is a risk of losing patients. Urine samples, e.g., for ruling out urinary tract infections, checking specific gravity, glucose, or ketones in an emergency setting. Yeah, there are certain cases whereby urine samples can be emergency or start ruling out a serious infection. And issues dealing with glucose, yeah, substituted glucose ketoacidosis. We check ketones or glucose, check the specific gravity to see, to counter check with glucose and see what is really affecting the patient. We have patient samples like pharyngeal and nasopharyngeal swabs for rapid respiratory pathogen detection, like influenza. As we all know that certain groups of influenza are considerably virulent and can cause serious infection. You remember how we used to deal with COVID-19? There are other cases like streptococcal infections, like group A streptococcus bacteria. Stool samples are less common for urgency, but they can be prioritized if specific highly virulent pathogens like Shigella, dysentery, type 1, or C. difficile, that's Clostridium difficile, are suspected and require immediate isolation, stroke management. There are other cases that we all know that, like Vibrio cholerae, and also including polio, because polio is detected in stool. These specimens must be treated with high priority, especially in suspected cases. We're going to look at general rule on priority, and in this we are going to check how this general rule affects urgent clinical decisions. So it's a general rule on priority and urgent clinical decisions. Now, look at blood glucose. I've stated before, issues dealing with blood glucose, they can be a priority depending on the state of the patient, especially patients with altered consciousness or suspected hypoglycemia or hyperglycemia, as stated earlier. Patients on monitoring of arteriovenous blood gases. These are used to detect pH levels, hypoxia, hypercapnia, or electrolyte imbalances in acute respiratory or metabolic distress. These are mainly patients in HDU and ICU, and some of these are monitored at bedside. So they are key priority specimens for handling with urgency, so that urgent clinical decisions are made if there are any critical issues that needs to be handled they can be noticed or noted urgently. Lactate is a key indicator of sepsis, shock, or ischemia, helping to evaluate the severity of infection or poor perfusion. Yes, as you can see, those details, these patients can really need utmost care. So urgency is needed for testing, especially if samples are indicated. Cardiac biomarkers is EG troponin, crucial for ruling out MI in patients presenting with chest pain. We have coagulation studies like INR, PTT, others are APTT, thrombin time, etc. These are vital for managing bleeding patients, monitoring anticoagulation therapy, or assessing a patient's suitability for urgent surgical intervention. Certain decisions are made in a split of a timer. If something is if there is a thromboembolic risk and that is almost occluding certain critical organ and leading to failure of such organ operating, and the antidote is not given quickly in sufficient time, the patient might not live. So coagulation studies should be keenly examined. If there is any that specimen, clinical history can dictate the urgency. Complete blood count provides rapid information on hemoglobin levels, especially for anemia. White cell count for infections, and platelet for bleeding risks. We are going to look later at how we report those critical values and the critical test results that we are going to obtain in such tests. We have tests like D-dimer, which is used to rule out deep venous thrombosis, that's DVT, or pulmonary embolism. As I stated about embolytic crisis, we have pulmonary embolism and deep venous thrombosis. This test is very key to for low and moderate risk patients. So when you see a D-dimer and there's a clinical history that's indicated there, to rule out, even if it's not indicated, start. Laboratory should understand should have the protocols of quickly triaging samples based on what we can capture from those requests. It's not a must that something is indicated critical or something is indicated as start. We should be quick and alert with a lot of discretion to triage specimens according to the needs that are there. We are continuing with the same. We have rapid infection disease panels that will fall into priority spaces. We have malaria rapid diagnostic tests and a blood smear in endemic areas for patients with fever. Yes, we are talking of rapid diagnostic tests and a blood smear. Mostly rapid diagnostic tests follow also blood smear, so they can be done together. We have also meningitis, stroke encephalitis panels on CSF. This is to rapidly identify bacterial or viral pathogens in CSF. We have tests for influenza, as stated earlier, and COVID-19. So there are rapid tests for checking for these infections. so that we control the spread of infections. You remember how COVID used to be treated? Yeah. So we are going to look at priority specimen and critical results reporting. Critical results reporting is also known as critical values or panic values. This involves the urgent notification of life-threatening laboratory results to the responsible healthcare provider to enable prompt medical action and immediate and ensure patient safety. At the center stage, we have a patient. At the center stage, we have the patient safety. And this patient safety is what is guiding us, especially in handling certain matters with priority. So we have two levels of criticality, the two levels of critical values. Level one or critical values. These are now the critical values, level one. These are results that show a marked deviation from reference ranges with no clear indication to the laboratory that these are expected deviations. Results of this nature may indicate a significant risk of life-threatening event. Prompt medical interventions may be required, as such, these results are considered critical. Results will be reported to clinicians any moment, 24 hours a day, 7 days a week. Underlying any moment, reporting any moment, 24 hours, 7 days a week. Don't wait for the clinician who handled the patient to come back the next day or the next hour. Whoever is available for patient handling should be reported to, or call directly the clinician who is directly in the care of this patient. Maybe this clinician can follow up with the one on duty for immediate handling of such critical value. Final classification of a laboratory test as critical is based on its laboratory value, as well as the patient's analytical history and any available clinical information. Yes, I will state this. I will briefly describe this out of some experience. Okay, maybe I give an example, a practical example that can happen. You've received a patient with a platelet count of 15. What do you do in such a case? So here, this is where medical laboratory scientists should be trained on fast action, fast discretion, especially in making decisions. What do? You have to verify these results very quickly in a split of time to check, to counter check whether your sample is okay, your machine is okay. If you have rechecked the second run and the sample does not show any sign of clots, kindly report this sample, this value as critical immediately. As you continue, if there is an equipment malfunction, you better communicate these results until further advised otherwise, so that you come back to review whether your machine is functioning properly or there is an issue somewhere. But in case you find there is a clot, because you are so concerned about patient safety, can you recollect the sample? So there is a possibility here of even recollecting a sample. That's why in the first clause here, we were talking about with no clear indication to the laboratory that these are expected deviations. So we should be very keen and we should be attentive to certain details for us to be able to work efficiently in patient safety. For this reason, not all lab results fall into critical range will be classified by the lab as true critical results for the purpose of immediate physician notification. Yes, you've seen a clot and you have to recollect the sample. That sample has to be recollected. And notification to the phlebotomist about the error. This is an out of control event, and it should be called, maybe if the sample is not collected properly, it should be followed by a kappa. The second value, especially on prioritization of the criticality, we have level 2 does not reach the threshold of critical value. They are on a lower threshold. They are called alert values or level 2 values. These are results that deviate from their reference ranges less significantly than the level 1 values. The level 1, as we know, we've stated, are critical values. If expected, these results suggest that there's a possibility of need to reevaluate the patient's clinical condition without waiting for routine report communication. Yes, if you've seen alert values that either need, they are not so critical, but they need some kind of intervention without waiting for the queue. Maybe the queue is 1 hour away. This patient might not be in a good state waiting for 1 hour. So kindly alert the clinician so that the patient is attended to. Urgency means prompt action in testing, clinical attention, and decision making. So prompt reporting of results for priority specimen is very crucial. It's crucial and also effective for patient management. The reporting process is tailored to the urgency of the results. Expedited communication is needed because high priority stroke critical results are communicated immediately to the ordering provider or their authorized representative via the fastest available means. Some cases might not, these cases don't need an email. They need a phone call. We also have a critical value reporting system. Many laboratories that are middle level to large laboratories have systems that are robust, especially in even reporting critical values. So there is a way in that system, and each and every lab scientist has to be trained on how to report these critical values in the system. You will report by a phone call, and also make sure that it's documented in the system, because if it's not documented, it's not done. What about when auditors come, especially maybe your accreditation is 1 month away or 1 year away? Doesn't matter whether it's 1 year away or 1 month away. You have to do right, even if no one is saying, for the patient's for the patient safety sake. Timely action is needed. The provider receiving the results is responsible for interpreting the findings in the context of the patient clinical condition and taking appropriate timely action. So when reporting through the system, this is already documented. This will prompt the clinician to take action. Yeah, and following by a call is a double prompt that this patient needs attention, needs my attention. So on the other side, the clinician, after documenting in the system, you will have offloaded your responsibility, your obligation you have transferred this obligation to the clinician. And following with a phone call, at least you've done something that at least you be confident that this patient will be taken care of. You've handed over to the right person. But if you don't report in the required protocol and things happen, you'll be audited. I see it's a time that I had given a talk on auditing processes. Auditing processes are key for patient safety. They are key for quality assurance programs in the laboratory. So auditors team will earmark this documentation that was not done and put a question mark on patient safety. So we have also impact on turnaround time. Prioritization means these specimens bypass standard queues significantly, reducing their turnaround time compared to routine samples. The overuse of STAT testing can, however, overwhelm laboratory resources and slow down the entire process. Yes, for me to emphasize on this, don't misuse STAT testing or STAT sample test triaging. They have to be used correctly. Otherwise, you might be using STAT in a wrong way, so that the real people who need prioritization are left out. Yeah. There's a patient who is in a hurry for his or her own reason, has influenced the clinician to indicate that the sample, the testing has to be done on an emergency state. And you go on and triage it into the queue of STAT tests. What about that real STAT test that was needed for the life saving of a certain patient? Maybe has fallen back the queue, and this has been that does not need urgency. Is the ones that don't need urgency are in front of the queue. What happens? The patient maybe who is very okay, and for him or her, maybe they need to be dispensed with very fast for them to go to their own errands. This is an abuse of the system and should not be encouraged. And how does it how can this be corrected? Monthly meetings in hospital settings are very important, and also communication and people to act professionally in their stations of duty. Next, we're going to look at public health priority specimens. So beyond clinical settings, some specimens are prioritized for public health surveillance to monitor diseases or antimicrobial resistance. World Health Organization Global Antimicrobial Resistance Surveillance System, that's GLASS, recommends the prioritization of specific specimens for monitoring common severe infections, including blood, urine, stool, and urethral and cervical swabs. Maybe this one needs to come in a different session, what GLASS protocols entail. And this one can bring up to us up to speed to which blood samples fall into certain categories of prioritization according to WHO GLASS system. Urine also, stool also. I've stated about polio and issues dealing with Shigella, dysentery, and others. How do we also treat? Are there also other samples like urethral swabs and cervical swabs that can be treated with urgency, especially under GLASS? So this is maybe someone will prepare in future and show and give us a broader picture on what GLASS entails. For this, reporting often involves immediate notification to public health officials for prompt execution of control measures and epidemiological tracking, even before final laboratory confirmation is complete. So kindly note, this one falls into our protocols of priority considerations. So we should take note of it. So we should learn what this GLASS entails and incorporate it into our protocols in the lab. There are key considerations and best practices that we should emphasize on. So we should emphasize on clear and accessible SOPs that detail what should be clearly done. And laboratories should have clearly written and readily accessible standard operation procedures, outlining specimen prioritization and rejection criteria. Training all laboratory personnel must be thoroughly done on proper specimen handling, prioritization, and rejection procedures. There's an issue of communication. Effective communication between the lab, healthcare providers, and phlebotomists is essential. Remember that issue where I was talking about maybe you've gotten an issue with low platelets of 15, and you have to make decisions with a split of time that so that some things are handled with speed and confirmed with speed, with high priority. How is your communication with phlebotomists? How is your communication with clinicians? How is communication between lab personnel? Yeah, to minimize errors and ensure timely collection of appropriate specimens. And also this will involve also reporting of critical values and handling of out of control issues so that the patient is kept safe. We have also regular reviews. You have to review rejection criteria and prioritization protocols. And this has to be updated regularly as need be to reflect the changes in testing methodologies, clinical guidelines, and regulatory requirements. Yes, so your protocols and SOPs are not cast on stone. Sometimes there can be abrupt changes that can come into place that will force you to make an addendum to an SOP, bringing on board the new measures that have come to your workplace or that have shown up in town. Testing methodologies have come and certain things should be confirmed. Yes, so priority is needed. This is where research falls in. Clinical guidelines, especially in handling emergency situations, outbreaks such as cholera and many others, severe respiratory infections, like COVID-19 and any other severe cases of respiratory infections. We have also regulatory requirements. Maybe some certain regulatory requirements have come in and you are supposed to report antimicrobial resistance to certain strains under WHO recommendations on GLASS. Remember the GLASS in our previous slide? Yes, they will make you change your protocols. They will make you change your SOPs briefly until that session is until that issue is gone. You go back and continue. Or there are certain testing for especially other routine tests can follow the rest of the previous SOPs as this as the new directives are followed in certain specimens. So that's what's needed to be considered, that SOPs are not cast on stone. They are things that can make them change temporarily. There are also documentations of all corrective actions in the laboratory. This is an emphasis that every action should be documented. So the conclusion is that not all specimens require the same immediate attention. Prioritization ensures that specimens from critical cases or those with time-sensitive diagnostic implications are processed first. This can directly impact patient care and outcomes. So this is the end of our presentation. Maybe I'll hand it over to my senior colleague, Emery, for moderation. I really appreciate
Thank you
my
so much.
distinguished colleagues.
Yeah, thank you so much, Mr. Agri. This was wonderful. We've loved your educative presentation today. And so we want to go direct to our question sections so that we can look at a number of questions that have been raised so that we can have to tackle them. A comment from Evelyn B. Gadoni. She says, a great presentation. And we have a question from Ocharo Eric to everyone. And the question is, which cardiac marker is of high priority? Our clinicians, majority of them request all the three. We can have a response on that, Mr. Agri.
Yes, there are various cardiac markers like troponin, CQMB, LDH, and many others. Now, I encountered sometimes back clinicians requesting for troponin, CQMB on patients who maybe are doing the test and as an outpatient test, and then there is no indication that these patients are on critical priority cases, and maybe the patient is told to come for the results later. I think this needs us to also be up to date in the information that we have on critical cardiac markers. Critical tests or emergency cases that needs to be handled, and what protocols are really that needs to be followed, especially in requesting for certain tests. So in the criticality nature of tests like troponin, it's not a test that can be requested as a routine test. This is whereby we need clear communication between the lab and also clinicians on protocols of requesting of such tests. Like now, this troponin and CKMB and LDH and also other cardiac markers, cardiac enzymes, should be handled on emergency cases. Troponin as an indicator of MI can be interpreted with other tests like CKMB, also LDH, and also other cardiac markers. But especially a patient with an acute MI cannot survive waiting for that test to come especially in the next 4 or 5 hours or so. This patient has to be en route to emergency care. And if there is a need, this patient has been referred. You don't have emergency care on the ground. This patient should be referred with a test to be done at the source of emergency care. So there are tests like LDH, which is general, can be general in nature, although it can indicate some cases of MI. It's to a lesser priority as compared to troponin, as well as CKMB also can be given a higher priority maybe next to troponin. So I've stated that I've listed them on a priority basis. Maybe that's what a consideration you can take into account. Yes, I hope I've answered your question. Thank you. Back to you, Mary.
Thank you so much. Let's look at another question that has been asked by our members. And the question is, let me check here. From Esther Bunja to everyone. And the question is hepatitis B positive of pregnant mother a critical value? Back to you.
Thank you. Hepatitis B to a pregnant mother cannot be regarded as a critical value as such, although it's a test result that needs to be handled with the care, but not criticality, unless there are complications that have arisen and they have been suspected to have arisen from the hepatitis itself. Maybe due to the clinical state of this pregnant mother, due to hepatitis, it's whereby it can be handled as a critical value. So it depends on the nature of the patient. As I stated earlier, that some indicators can inform us the priority, the priority category, prioritization category of the same.
Thank you. Let's look at another question from one Elias Wayodi, and he's asking if acute suspicion of kidney injury, how will we tackle this as a laboratory? How will we tackle acute suspicion of kidney injury?
Thank you. Thanks a lot. That's a good question. Acute kidney injury comes in with certain parameters that are very key, especially potassium. Potassium is when potassium is deranged in a patient, we should handle it as a critical value. It must be handled as a critical value and must be reported immediately. So with acute kidney injury, there has to be deranged potassium levels. And acute kidney injury, the first thing that you should handle there, don't even consider so much about creatinine and BUN or urea. Just if there is an indication of acute kidney injury, and this is followed by the state of the patient, also it's indicated in the clinical history, kindly run electrolytes immediately and check potassium. potassium level is deranged, report it as a critical value. Follow up with the clinician as a critical value. So that one will confirm acute kidney injury and the need of quick attention to this patient. Thank you.
Yeah, that's a good response. Let's look at another question. Zedi Otieno is asking, in which conditions can USCs be considered an emergency test? Back to you.
Yes, thank you. That's a good question. It follows up with the previous one. Yes. So when kidney issues are considered, electrolytes are considered as an emergency test, it follows certain conditions such as acute kidney injury. We have nephrotic syndrome. We have nephrolithiasis. We have anything associated with kidneys should be handled with a lot of care, especially when we should consider calcium with the highest sodium, potassium with the highest priority. Other cases involving diabetic issues, other cases involving heart conditions and hypertension issues, the cardiovascular illnesses altogether, and indications that might indicate that there are certain issues dealing with kidneys. There are also hemolytic conditions that are severe hemolytic conditions that can impact the life of a patient. Should be followed by emergency regard to electrolyte testing. So you see, there are a list of issues there, but what is needed in us is what discretion can we make from a clinical history, and this clinical history, how do we are indicated in this patient? Maybe the patient has come with a number of very sensitive tests. Troponins are there. There is LDH that's being checked on. There is also AST. There is also there are also electrolytes. When you see such a patient, even if it's not indicated that this patient needs to be handled under emergency or high level of priority, the tests talk for themselves. So you should handle electrolytes as urgency with the greatest urgency, the same as you handle creatinine, troponin. Sorry. So thank you for the same. Back to you, Emery.
Yeah, thank you. More questions are coming in, and let me go through some of the charts here, very educative charts that you're getting. And one from Ocharo Eric, and he says, sometimes our clinicians subject us to report results as critical due to poor sample collection technique or integrity. Others end up drawing samples from infusion lines for analysis. Another statement and response from another colleague, that is Johnson Masiga Maibei, also says, a diagrammatic presentation of this can be very helpful apart from the SOPs, just like it is with epidemic disease where there are guidelines. You can take note of that, Mr. Agri, and maybe
Yes.
think on what you can do as an expert in this area. And then we also have another question from Maurice Masharia, And he says, is a high AFP in a first trimester mother critical for intervention? That is 23.03 nanograms per mils, in bracket 0 to 7. Kindly respond to that, please.
That's alpha fetoprotein. Is it AFP? Alpha fetoprotein, yeah?
Yes, AFP.
Okay. So AFP is a test that, okay, now this is a pregnant woman. This is a pregnant mother. And what we are looking at here is the checking of the we are trying to check the we are trying to check whether, okay, we are talking about the liver issues and hepatitis, yeah? And this AFP is high. As an indicator of hepatocellular carcinoma, so this is an indication of a risk pregnancy. As earlier stated, I was talking about the patient status and considerations that should be therein in considering, especially in considering this test as a priority test, so that this patient is handled with the care that the patient deserves. Of course, it can be a high priority test, but does not reach the threshold of critical value. And the reason is this: hepatocellular carcinoma is not something that can be that progresses. Okay, that acutely progresses, and the moment is diagnosed, it, if not handled immediately, can cause fatality. Of course, the end of it is fatality and can quickly come. However, the patient has to be handled on priority cases, on priority basis. This is whereby we had categorized the priority basis on critical. First is critical, that's panic issue, panic values, and the second is level 2. Level 2 is high priority specimens or tests. So this is a patient who is supposed to be referred to specialist care and specialist attention. So an alert is given for the same. The alert that is given here is not the same as the critical value alert. Thank you. I think that's how I can answer that.
Yeah, thank you. Thank you for that response. Let's look. Let's check on our Q&A section again and come up with another question. Let me check from Frederick Musango. He's asking, why is RBS considered critical in severe alcoholic patients? Back to you.
Thank you. In severe alcoholic cases, yes, you see, let's go back to chemistry now. If you look at the structure of alcohol, the structure of alcohol looks similar. The difference is only hydroxyl ions with the glucose. The structure is similar. And why sometimes alcohol can really cause derangement of blood sugar is due to the similarity of the structure. Now, severe alcoholism can lead to hypoglycemia, and that's why people feel drowsy and and they feel tipsy and drowsy and with altered mental status. Um, so such cases, especially of alcoholism-induced hypoglycemia, can be okay. It's something that's I don't know how I can explain it. But this is an issue that's self-limiting. But if you find that someone is diabetic and is indulging in severe alcoholism, it's a very dangerous precedence because there's this issue of DKA or or um, or diabetic coma, especially in hypoglycemic cases, and also hyperglycemia were followed by DKA. Because alcohol usually will cause derangement or constant fluctuations or serious derangement of this parameter in the system, leading to poor control, and also it can lead to dangerous precedents such as coma and DKA. So this is whereby sometimes it's difficult to differentiate a person who has collapsed due to DKA or alcoholism. You might not notice unless someone knows this person. So unless unless someone knows this person is able to identify that this is an alcoholic and is diabetic. So when it's known this way, and this person has just collapsed, and this person was not too tipsy, it was not so much tipsy to an extent that that could warrant falling asleep by the road. This is an issue that should be considered for emergency case. And the blood sugar is analyzed and the levels are checked. If hypoglycemia is confirmed, then swift response should be taken. And also in cases of hyperglycemia, the issue is handled efficiently so that to prevent fatality. And there is this issue also of considering knowing the blood sugar before any intervention is done. You see, this is why constant communication between the lab and the clinical fraternity on such issues, because intervention can be done in a person who is hyperglycemia. You've added dextrose and you are killing this patient. Or hypoglycemia, you don't know what to do. You know whether it's hypoglycemia, you don't continue with any intervention. Or you think it's hyperglycemia, the person is given a wrong medication. What happens? So discretion is needed, a lot of understanding. And also professional practice is key in understanding, because someone has to be awake or to be alert before handling certain cases. Thank you. Back to you, Emery. Thank you for that question.
Yeah, thank you. As you tackle your last question and then you go ahead and give your parting shot, there's a last question from Benedict Omondi, and it goes: is V. cholerae positive on RDT or on culture should be considered critical value? I'm repeating the question, and it goes: is Vibrio cholera positive on RDT or on culture should be considered a critical value? But please tell us if there's any critical values in parasitology or BTS not worth noting. So you can answer that and proceed to give your parting shot, because we've depleted all our questions and our time is also nigh. Thank you.
Thanks for that question. Yes, there are critical values in parasitology, including malaria. Malaria is one of them. Malaria is a critical issue in parasitology. We have Brucella. It's a critical result in parasitology. No, that's in microbiology. And there are these issues concerning Vibrio cholerae. The essence of rapid diagnostic test kits are there to screen, but there are tests that are there to confirm. So screening will enable a clinician compare the results from this screening of a rapid test with a clinical picture to make a quick clinical decision. So if the picture tallies with the clinical picture tallies with the results for cholera, further testing must be done. That is confirmatory testing. But as we wait for confirmatory testing, which is culture or other molecular tests that are faster than culture, treatment continues to cover just in case there could be cholera. So treatment is ensured immediately upon the test being positive. And again, there's something that I didn't put emphasis on about repeat of tests. There are, for the critical test, it's good for us to confirm our results, consider repeating a test. Maybe there is an issue with your testing system, maybe pipetting, or maybe the sample collection, or maybe the other things that can prompt us to double check whether our methodologies are functioning correctly. That's why we need to repeat. However, for cholera cases, if there's a clear indication that there is cholera in town, and there is this patient, the sample, the sample appearance, the state of the sample, the state of the patient, etc., etc. Then this sample should be reported as critical. As I've said, it requires quick discretion, prompt action, and prompt reporting. Thank you. Back to you, Marie.
Thank you so much, Mr. Agri, for this wonderful presentation. To our participants, we also appreciate a lot your participation in this particular webinar today. On behalf of Lab Medicine, my name is Arthur Imari, your moderator today, and we welcome you again tomorrow for another insightful presentation. Have a good evening.
Thank you.